Melanoma Patients Australia has been around since 2006 and is the peak national melanoma body developed by patients for patients. Our organisation is about supporting friends. It's about a network of support and information, providing you with guidance in your journey and enabling you to feel empowered and to focus on those positive things that can come out of quite a traumatic diagnosis, to dealing with the uncertainties that melanoma presents, and understanding that through peer-to-peer support and talking to someone who has perhaps walked a similar journey, we can find strength, love and friendship. So unfortunately, melanoma has the highest incidence in Australia. We have over 1,500 people who pass away from melanoma each year, and Queensland particularly is a hotspot, and Townsville does have a high incidence. So today we are joined by Dr. Abhishek Joshi, who is from the Townsville Cancer Centre, and he'll be able to speak to us from the point of view of a medical oncologist to tell us about some of the developments that are going on in melanoma treatment. In the last 40 years, melanoma treatment has been very standardised, and we've seen perhaps in the past 5 years some amazing advances, which is making it a really interesting time for a clinician in treating melanoma, but more importantly for patients, it's giving options. But with options do come some questions, and it's really important that we have expert advice and guidance about making the right choices for our journey. So I'd like to invite Dr. Joshi up.
So I'm Abby, I'm one of the medical oncologists here at the Townsville Hospital, and primarily my involvement in melanoma is with patients who have got advanced disease once the cancer goes beyond your skin to involve other areas of your body. So what I'll do is I'll kind of cover melanoma right from the basics, just to give you a brief overview of what melanoma is, how it sort of evolves, some clinical presentations, early symptoms, and then as we go on later, more into my realm of how you treat advanced melanomas. Melanoma is Australia's national carrier. We're the country with the highest incidence rate of melanoma, with more than 10,000 diagnoses made every year, a tenth of them dying from this disease. It is the third most common cancer, both in men and women in Australia. And Queensland, by virtue of being closer to the equator and the geographical demographics, is the state with the highest incidence of this disease. The also concern about melanoma is that the incidence is rapidly rising. It has doubled over the last 20 years, although we know that most of the cases are detected early and are curable. So we're all aware the stem cell or the genesis of melanoma lies in the melanocyte, which is the cell within the uppermost layer of the skin that produces the melanoma pigment, which gives the color to the skin. And the first stage in the development of melanoma is an abnormal proliferation of cell within that first layer itself, which we commonly call as stage 0 melanoma, where these cells have actually not gone beyond the upper pink first layer down into the lower layer, and that's called melanoma in situ. This condition, melanoma in situ, is almost 100% curable. And as a next step, as these cells invade the first layer and go down deeper into the dermis, that's where the risk of distant disease comes in. The layer of the skin below the epidermis, which is the dermis, is laden with a lot of blood vessels and lymphatics, and these sort of provide a migrating channel for these small cells to escape into the other parts of the body. So on the face of it, melanoma can be a very subtle disease to diagnose in the fact that a lot of these are benign-looking nevi to begin with, and so early signs to pick this cancer up are very important. And we sort of list them down into the mnemonics of A, B, C, D, E, F, G, where A stands for asymmetry, B for border, C for change in color, and D for change in diameter of an existing mole or nevi. And in some of the other forms of melanoma, the nodular melanoma, you can then get elevations in these nevi, or the consistencies can change, and there can be rapid growth. So these are some of the typical early signs of melanoma: change in the border, change in color, change in symmetry, And as you go ahead, then you can have nodule formation. When you'll talk to your dermatologist or your GP, they will be informing you about some telltale signs like the ugly duckling sign, which is very typical for melanoma. The other sign is the red herring sign. But these signs are not always present. They're characteristic, but they're not present in all melanomas. So the commonest types of melanoma, superficial spreading is the most common type of cutaneous melanoma. Basically, this is a melanoma that spreads tangentially across your skin, and it's related to chronic sun exposure. The nodular melanoma, where nodules are formed, is the most aggressive type. This has the propensity to penetrate down deep into your skin and involve the lymphatics and blood vessels. Another type that you'll come across speaking to your doctors is what they call as lentigo maligna melanoma, and there's a bit of discrepancy around its nomenclature as to whether it represents early melanoma or true dysplasia. But this is a very early form of melanoma. Mostly it refers to a melanoma that has not actually invaded the first layer of the skin and is curable. The other type is the acrous lentiginous melanoma, which typically appears in non-sun exposed areas like the sole of your feet or palm, which don't have much of hair follicles. And this is not related to sun exposure. So this is how a superficial spreading melanoma looks like. A nodular variety. The melanoma in situ, common sites are face and upper trunk in elderly people, and the acral lentiginous melanoma. One of the other forms of acral melanoma is sometimes it can be found in the mucous membrane beneath these nails. And then you can have melanoma in all the unusual sites as well. For example, within the esophagus or the food pipe, or in the mouth, or in the rectum, or even in the eyes. So we're all aware with the risk factors of melanoma. Sun exposure and UV radiation is by far the most important one. Again, with ultraviolet radiation, the B radiation is more specific for melanoma than A radiation. And that's the reason that countries that have a more equatorial demographics, which are exposed to more ultraviolet B radiation, have got higher incidences of melanoma, as opposed to countries that are away in latitude towards the poles. Also important is the timing and the pattern of sun exposure. So there's been an association of melanoma with intense exposures to sun causing sunburn rather than a chronic exposure. Patients with psoriasis who have had previous PUVA therapy have been shown to have higher incidence of melanoma than the normal average population. Again, with nevi, there is higher incidence of melanoma seen with either high number of normal nevi or any atypical nevi. Genetic predisposition and mutations in some genes are responsible for 10% of melanomas. A prior history of melanoma does predispose you to a higher risk of for a subsequent melanoma. And also a non-melanoma skin cancer is a high risk factor for a subsequent melanoma. And that's, I think, in a way related to sun exposure. So when there's a suspicious lesion, most of the times your GP or your surgeon will talk about biopsying the lesion. And the biopsy is important to characterize the lesion and nowadays also to understand the genetic makeup of that lesion so that we can know what sort of therapies, if at all required in the future, could be used for these sort of cancers. And once the biopsy is done, the pathology report would have these mentioned in it, which are the ways of expressing characteristics of the melanoma, so the thickness, the ulceration, the Clark level, and the mitotic rate. It's a bit unfortunate some of the pathologists' centers don't actually report all these factors, and then it's the onus on your GP or your surgeon or your oncologist to actually proactively talk to them and make sure that all these factors are given within your pathology report. So thickness is basically the depth of the melanoma into your skin, and it's measured in millimeters. Clark level relates to the invasion of melanoma into the layers of the skin, And this is important because the risk of spread is directly related to the depth of the level. So the higher Clark grade the melanoma is, the higher risk of it spreading. And then depending upon the type of melanoma, your GP or your surgeon or oncologist would request some tests to stage the cancer. And some of the tests that we use commonly for melanoma are a CT scan, which can pick up disease which is not visible from outside. PET-CT scan is a more newer modality, which is more sensitive than a CT scan. It's got a functional component to it, so it can pick up activity within cancer cells. MRI scan is used typically for melanomas in brain, where PET scan and CT scan are not very sensitive and small lesions might be missed. Bone scan is used to evaluate, as the name suggests, bone, which is one of the areas where melanoma can spread. And once we've got these scans results and the pathology report, that's when we stage the melanoma. So it's basically based, the staging is based on the tumor, the nodal involvement, and the presence of distant disease. And you have got 4 stages. Stage 1 and 2 is localized disease within the primary site, be it skin, be it your eye or the oral cavity. Regional metastasis, or stage 3, typically refers to the spread of the disease to the first or the closest lymph nodal drainage area. And why we are trying to separate it from stage 4 is that this category of patients still can be salvaged with curative intent. And distant metastases is the spread of the disease beyond the regional lymph glands to other areas. This slide just tells you that with how primary tumor impacts survival. So just with the Clark depth of the melanoma, if the depth increases from stage 1 to stage 4, the 10-year chances of living go down from 90% to almost half. So that's why a pathology report is so important. And then depending upon the numbers of lymph nodes involved, the melanoma gets upgraded. Nodal involvement is a prognostic factor in melanoma. Again, within the metastatic disease, the number and the types of organs involved also play an important impact in what treatment is to be planned. Very few patients with stage 4 melanoma who have got low volume disease can still be amenable to surgery and can look for long-term cures. So typically a surgery would involve what we call as just the excision of the melanoma with some margins of normal skin around it. And a second procedure called a lymph node biopsy, which drains that particular area where the tumor is. There is now standard guidelines laid to how much of the margin of normal tissue should be taken from around a melanoma. And usually your GP or your dermatologist would refer you to a surgeon if there's any complicating matters in this regard. And then once the melanoma is excised, depending on what area the tumor is excised from, the wound can be closed either by stitches or possibly requiring a graft or a flap if there is a bigger defect. Again, the lymph nodal status is the single most primary factor which will determine the absence or your survival in the long term, and hence if there are high-risk features within your pathology report, usually now a procedure is performed which is called sentinel lymph node mapping, where attempt is made to see whether the tumor has gone to involve the first station lymph node. So depending on the site, this could be either in your neck or the axilla or the inguinal areas. This is the technique is a minimally invasive technique, so it doesn't require a big surgery. And the advantages of this technique is it allows focused examination of the first draining lymph nodes and can provide us with prognostic and staging information. Rarely this can be false negative. So this is just a cartoon to show that if there's a melanoma, primary melanoma in the leg, the draining lymph node is in the groin. And so if there are high-risk features within your primary melanoma, your surgeon might actually discuss this procedure with you to map the lymph nodes in the groin. And this is how it is done. So basically, a dye is injected in and around the tumor. So sulfide colloid is one type of dye. The other dye is just a simple blue dye. And the concept is, the hypothesis is that it will, if the melanoma is deep enough to involve the lymph glands, the dye will travel through the lymphatic channels to the nearest lymph node. So that's how the dye is injected through a syringe. And then if the lymph glands, and then the surgeon looks at the lymph nodal area, and if there's a lymph gland involved, the lymph node would take up the dye. So these are some of the areas in the body where this sort of procedure would be discussed with you or performed if required. So how do we treat these patients? So at the Townsville Hospital, we've got a melanoma skin clinic every Friday afternoon where all the experts come in together to discuss cases which are high risk, typically stage 3 and stage 4 melanomas. And we try and discuss the best sequencing modality, the best modality and the sequencing of modalities of how to treat these cancers. So the treatment options are surgery to primarily remove the tumor. Adjuvant word is used for any treatment that is done after surgery with an aim to cure a micrometastatic disease and reduce the risk of relapse. And with melanoma, currently there are 2 adjuvant therapies which are available to treat high-risk patients. So one is the immunotherapy with interferon, and second is a targeted therapy. And then there is role of radiotherapy to treat these cancers if it's a bulky lymph nodal disease, primarily for loco-regional control benefit. This is this is just a graph to show the results of a trial, a worldwide global trial of interferon versus no treatment in high-risk melanomas. And the blue curve is the curve which did not receive any treatment after surgery, while black curve is the curve for high-dose interferon. And on the x-axis, if you can see, 50% of patients in the blue curve are surviving just less than 4 years, while with high-dose interferon, it's up close to 9 years. The problem with high-dose interferon is that it's a toxic treatment. It's not a treatment for everybody. So your oncologist will discuss this therapy and select the best patient for this sort of therapy. It's still not a very popular therapy used in Australia, primarily because there have been this trial was published from United States, had a few European centers, but when this study was reduplicated in Europe, what it showed was high-dose interferon does disease the chances of melanoma coming back, but it doesn't actually change your survival. In Townsville, we are offering this therapy to selected fit patients who are young and who have had a high-risk melanoma resected. So coming to the most difficult part of the problem, the stage 4 melanoma, when the cancer has gone beyond the skin to involve your distant organs. And again, the decisions for treating these sort of patients are taken in our melanoma clinic. Primary aim of treatment with advanced disease melanoma is relieving symptoms and prolonging survival with a good quality of life. Nowadays, there are therapies where we can talk about possibly curing a very small percentage of patients, but we still don't jump the gun and use that word cure for stage 4 patients initially. So surgery has got a role even in stage 4 melanomas when they have gone beyond your skin to involve distant organs. And this is when you have, when somebody has got a very limited disease in 1 or 2 organs, which can be excised. And some patients do derive long-term benefits from this sort of approach. So surgery is an option. The primary treatment here is medical therapy that I'm primarily involved with, and we've got multiple types of treatment here. I'll talk a bit more about them. So immunotherapy, anti-BRAF therapy, anti-MEK therapy, and chemotherapy. And radiotherapy has got a role in these sort of advanced cancers, primarily, again, for symptomatic control of brain metastases where chemotherapy penetration is poor, or patients with bone metastasis for pain control. So what are the currently approved drugs in Australia which are reimbursed by Medicare for these sort of stage 4 cancers? So chemotherapy has been there for a while. There are 2 drugs currently approved. And recently, just only last month, ipilimumab is the new kid on the block that has just been approved. So chemotherapy in melanoma has been there for the last 4 decades now. It got approved in an era where there was absolutely nothing for these sort of cancers. And so any sort of responses were taken as a positive sign, but you can see that the response rates are quite dismal. And again, the survival, median overall survival is less than a year. The advantage of chemotherapy, though, is that it's a very quick acting treatment, so you get faster responses. But now with the advent of newer molecular targeted therapies and immunotherapy, it has fallen back in terms of the priorities of selection. So this is the new drug, Yervoy or ipilimumab, which has just been approved in Australia. And how it basically actually works is it sorts of removes the brakes away from the immune system on your body. So immune system as a target for treating melanoma patients, the concept arose from the idea that immune system takes care of anything in our body that is foreign, and we know that. As kids, all of it, we get vaccinated against infections, and some of these vaccines produce antibodies with the help of immune system and give us cover for lifelong. So the concept came that if we could trick this immune system in recognizing melanoma cells as foreign, maybe the immune system could fight this cancer, and that's what ipilimumab does. So CTLA-4 is a powerful brake within the immune system which keeps the immune system under check. And what ipilimumab does is it sort of blocks this CTLA-4, so it removes that brake and it unleashes a massive response, immunity response against the cancer. And although this drug was approved last month, I just put this slide to show what goes into development of a drug. The development actually started in 1990, so there's a fair bit of history about developing ipilimumab. And it was first discovered, the university patented the CTLA-4, and then Nexstar purchased the rights, and then it changed a few hands. Medrex then purchased the patented rights from Nexstar, and then Bristol Myers Squibb, the company which is commercially marketing this drug in Australia, they joined hands with MedStar in 2005 to commercially starting developing ipilimumab. So actually quite a lot goes into developing a drug. And so these are the results from the worldwide global study that actually put ipilimumab in the forefront of melanoma therapy. So this was the first drug to show survival advantage in stage 4 melanoma patients. And you can see that patients who've had this drug with chemotherapy versus patients who have had chemotherapy alone, 10% more patients, close to 10% more patients are surviving at 3 years. The other good thing about ipilimumab is the durability of response. So of the patients who respond, 90% of them have got long-term durable responses. So in this trial, all but one patient who responded to ipilimumab had their cancer under control and up to 99 months. So that's almost close to 8 years. Also, you can see there is a 15% complete remission rate. Complete remission means no radiologically visible cancer in the body. So, and when you have that sort of response and durability for 8 years, you're possibly getting signals that some of these patients are likely being cured. We don't know yet. So this has overtaken chemotherapy now, and it is the drug of choice for stage 4 melanoma patients. Our unique feature about ipilimumab is the response, the pattern of response. It's very different from chemotherapy. So the cancers can initially actually progress after ipilimumab, as seen in this slide. So at 3 months, you can see that the cancer actually looks more worse. But then towards the 6-month, 8-month mark, the cancer actually starts showing response. So this sort of patterns of responses you're seeing now with more newer therapies. So the tricky part of ipilimumab is the toxicity, which is a toxicity of an unchecked immune system. And so autoimmune side effects can be quite severe, and in up to 15%, they can be life-threatening. So that has to be discussed with your oncologist. There are guidelines to manage these toxicities, and I guess that's a risk that one has to weigh in before considering these sort of treatments. So there are some patients who are not suitable. For example, if somebody has got a background history of autoimmune disorder, that sort of patient would not be a good candidate for ipilimumab treatment. The other immunotherapy for advanced cancers, I've just put this slide, interleukin-2. This was actually the first therapy to show survival benefit in 1998 and is currently used only in United States, primarily because, again, the toxicity associated and the limited expertise with this sort of treatment. But again, the signals, ipilimumab signals mimic interleukin-2 signals, so you get complete responses in some patients, and they are very long-lasting. So there are other CTLA-4 drugs which are being tried and are currently in clinical trials. Nivolumab is one example, and again, you can see that there are durable responses with this sort of therapy. Lambrozolumab is another new drug which is available in a clinical trial in Brisbane, and the response rates are better than ipilimumab. We only have got 7-month data, but there are 80% of patients who are disease-free at 7 months after having this treatment. So we are hoping that these drugs become commercially available soon. The second approach for treating stage 4 melanomas now is targeting the BRAF pathway. And if you see on the cartoon on your right, BRAF is one of the oncodriver pathways in melanoma, which is responsible for cell proliferation. And the good news for melanoma patients is that this pathway has been found in more than 50% of patients with cutaneous type of melanomas. It's close to 60%. And if there's this switch present, now we have got drugs that can target this switch and switch the switch from on to off. And the advantage of this sort of therapy is you can get dramatic and rapid responses. So vemurafenib is the drug which is currently available in Australia, but not PBS reimbursed. We're hoping it would come on a Medicare list fairly soon. The slide below just shows the benefits in patients. The thing to take home is when you have the curves which are too wide apart, then it's a good sign for the drug. And these are some of the responses to vemurafenib that we have seen. Vemurafenib was available in Townsville last year as a part of clinical trial, which is now closed. So we had some patients with dramatic responses on vemurafenib. All the orange and yellow is the cancer, and you can see that after vemurafenib, 2 months of treatment, there is substantial reduction in the tumor burden. Side effects with vemurafenib treatment, the most common ones are secondary skin cancers, squamous cell carcinoma of the skin. But other grade 3-4 toxicities, as you can see, are rare. So it's fairly reasonably well-tolerated drug. So there are other BRAF inhibitors that are out there, again in clinical trials, not in the market. So one is dabrafenib, and this has also shown better results compared to chemotherapy. One of the other pathways that we have learned in melanoma disease progression is the MEK inhibition, which is sort of a switch which is more down to BRAF, and so is more effective even in patients who have failed BRAF. And this drug is again available in Australia within a clinical trial, and results have shown that combination of this MEK therapy with the BRAF therapy together has shown better results than BRAF therapy alone, but these are very early results. Trametinib and dabrafenib can be got to treat patients through access programs. And then there are all these other molecular approaches. Just on your right up there in the violet box, c-KIT is another switch, and there are drugs to target c-KIT, which are commercially available for chronic myeloid leukemia and some other cancers, and now are being tried for melanoma with some responses in early trials. So when you have all these sort of therapies, so which therapy to use and when, and so, and obviously that's where the role of high high-risk melanoma clinic comes in, where we discuss patients and debate over what literature is available, what's the evidence. But in general, for us, in treating stage 4 disease, if there's a fit patient with low disease burden, despite BRAF switch being present or not, we would prefer ipilimumab because of the durability of responses with this therapy. If there's a sick patient with higher disease burden where we are looking for rapid responses, and if there is BRAF mutation present, we would go for BRAF therapy, and ipilimumab would then be reserved for subsequent maintenance treatment. Clinical trials are also options to enroll patients with stage 4 disease. And as I talked before, chemotherapy has now fallen back, but is an option again when you're looking for rapid responses. BRAF testing currently in Australia takes around 3 to 4 weeks. And if you have got a cancer that's rapidly progressing, one approach is to send BRAF mutation analysis and then start chemotherapy and then tailor therapy once you've got the results. So I'd like to conclude. Early detection and prevention is still the best method to reduce mortality with melanomas. Surgery is the only curative treatment in early melanoma. Tumor thickness and the nodal status are the single most important factors, so it's good to have a thorough pathology report. Adjuvant therapy to prevent melanomas with high-dose interferon is available for high-risk patients and selected patients. And immunotherapy and anti-BRAF therapies are the only current to systemic therapies that improve overall survival in stage 4 patients. Thank you.
So thank you, Abhi. That was very comprehensive, and I think it definitely showed the full spectrum of what we as a patient group are dealing with. We can see the early stage right through then to the more advanced disease and some of those decisions that our members are having to discuss with their treating clinicians. And I think that your overview provided us with a bit of insight. So hopefully when we go to see our doctors, we're a little bit more equipped and armed with some information. Does anyone have a question at all?
I see you inject the dye in there, and the dye followed the roots of the melanoma to where it went to. It's strange to think that they haven't come up with a chemical like Roundup that's systemic, that can kill the cells as it goes right through to the end.
There are approaches in that aspect as well, and I didn't bring it up primarily because they are surgical. So what we have now, one method of approaching this sort of method is what we call as intra-arterial limb perfusion chemotherapy treatment. And we've now treated 2 patients at the Mater Hospital where this is specifically targeted to patients with melanoma, which is localized to one limb. And as you pointed out, if there's no melanoma elsewhere, then you would want to give some treatment that works just in that area and spares you of the toxicity in the rest of the body. So in this approach, what's done is a tourniquet is tied in that limb, and the blood supply to that limb is actually blocked for half an hour, and heated chemotherapy is injected directly into the arteries within that limb to circulate it for some time, and then it's washed out and the limb is closed. And this approach is for specifically, as I said, patients who have got melanoma restricted to a limb. The good thing is it can be done for even elderly patients. The last patient that we have done is 92 years old, so there's no age limit. And in-transit melanoma within the limb can be a significant morbidity. So yeah, I just didn't bring that up because it's more surgical. Yeah, so that's a valid approach for localized melanomas. The worry with other melanomas is that we don't yet know if there are small cells that have swept into the system elsewhere, and you would want to take care of that. So
I guess my question just relates to the genetic disposition, and also obviously from an early detection and prevention perspective. Do you foresee in the future that we might have some kind of genetic testing process for people who have children who are stage 4? I understand that genetic testing at the moment focuses on tumour, on the tumour itself and the cells that exist within that. But I'm just thinking from a future perspective, is there any way for any early recognition that you might have a predisposition?
With melanoma, the only gene at the moment that has shown to go down the hereditary pathway is a CDNK2 gene. Um, the difficulty is that the incidence of this, because the incidence of this genetic mutation is so low, you only retrospectively identify if you've got history of melanoma within the family. The problem here, I guess, in terms of practical perspective is that within the Australian population, melanoma, especially in Queensland, is so common just because of the sun exposure. Unless this gene testing becomes readily available at low cost, it will be hard to select patients whom to test, because I see patients with different cancers who've had multiple family members with multiple melanomas excised. So you never really know whether they carry the gene or not. So, but that's something which science always looks for ahead, and I'm hoping that if the test becomes easily available at less cost, you could probably do that. I'm at the moment not aware of any other genetic predisposition apart from this particular gene, but as I said, because it's only in 10% of melanoma patients, at this point we don't know which patient to select for this test.
The part that interested me was where you injected the dye in the, well, not you personally, but the dye was injected in the early stages. And I had a primary in my right knee, and it's subsequently progressed to a secondary with some pretty large lumps in my right groin. And they injected the dye, and I obviously now know what happens. It sort of travels up the stream and it changes the colouring of the lymph node. And I've asked the question many times as why in that situation wouldn't they have sort of taken out a bit of insurance and, in a layman's term, gone further upstream instead of stopping at those particular nodes that were highlighted with the dye. If they'd have gone a little bit higher, it might have saved things subsequently.
I guess every procedure has got some morbidity associated with it, which you have to weigh in when you're trying to do a procedure to cure a disease. So with the lymph node dissection, the more lymph nodes you remove, the more chances of subsequent lymph swelling, lymphedema, which can be a significant morbidity issue for a lot of patients. And so you have to kind of balance between try and get the nodes with the cancer in and leave the ones which you feel don't have cancer. So one way of doing that is sentinel lymph node mapping and a PET scan. So sometimes PET scan gives you an answer and maps the disease beyond the sentinel lymph glands, in which cases you would remove those lymph glands. Or if they're bigger in size, even though they don't light up on CAT scan or a PET scan, but they're more than a centimeter in size, usually your surgeon will remove that node. But if there is a node which has not got any high risk features, so does not map on a sentinel lymph node, does not light up on a PET scan, is smaller in size, the chances of having melanoma in that lymph node is very low. And then the whole question arises is whether to do the procedure and subject the patient to the morbidity of lymphedema versus that chance of so. So I guess that's where the art of science is, and many times we get caught on the wrong foot. So yeah. But there are advances there as well, and I'm not the best person. I'd probably be speaking to your surgeon about this, to try and make more specific tests with less false negative results, which can exactly map the lymph glands to where the cancer is and then remove them.
I just recently met a friend of mine who's had the use of rose Bengal in his treatment. Rose Bengal, which is it's I don't know if you guys are aware of it, but it's injected directly into the melanoma. I'm just wondering if you know any more about that. I know he had melanoma in transit and had really good results with the use of rose Bengal. And the second point to that would have been if they're able to inject rose bengal into the melanoma and have excellent results around curative or the removal of that particular melanoma, why can't that be used in isolated sites?
Yeah.
It has a technical name to it, but it was introduced to the world, I suppose, or to the layman as rose bengal, and has been tremendously successful in melanoma in transit, and similarly used as lower limb infusion. Whether that's a trial or something being run specifically by Mark Smithers could be the case, but I'm just wondering if you'd heard anything about it yourself.
No, yeah, unfortunately I don't have any experience with rose bengal, but there are a lot of drugs like that out there for in-transit melanomas. As you know, the current series with the highest or the best results are still with, as I said, with intra-arterial chemotherapy. So that's something that we have been doing here, but yeah. So yeah, I haven't heard about the rose bengal. Yeah.
And recently I heard there are a number of BRAF type genes like C and K, and we don't hear a lot about that either. So BRAF-C is the more popular and K is the least popular.
So yeah, so you have got E, K, C mutations within the BRAF. So depending on where in the genome that mutation is. So the drugs that we use currently are the ones that target the E mutation, but the newer ones that like dabrafenib, it targets both E and K. So that advances in trying to get to target all these mutations at the same time.
10 years ago, we only had dacarbazine and fatamustine, and I think we really are on the cusp of some beautiful things, and thank you for your efforts as well.
I have a question about amelanotic melanoma. It wasn't on your list of, quite extensive list of different melanomas, and we came to know that personally. So it seemed to be rare at the time, but I believe it's becoming less rare, perhaps more recognisable.
As the incidence of melanoma is rising, the amelanotic melanoma incidence is rising. Typically, it's characterized by the absence of the black pigment, and so can very often picked up late because of no changes seen. In terms of therapy, it doesn't really change things. If you've got a particular mutation to target, you would give the same sort of treatment. But that's an important factor for doctors who are involved in screening of melanomas, primarily your GPs or your dermatologist, to know that there is this type that exists.
If you're receiving a blood transfusion, what are the chances of picking up a melanoma cell in that blood transfusion? And on the flip side, if you're a blood donor and before you're diagnosed you donate blood, are the people who have received your blood notified that there would be an increased chance of a melanoma cell infection?
Yeah, that's a good question. No, I haven't heard of that sort of increased incidence. The problem with, the problem is we don't have any test to diagnose melanoma cell in the blood. There's no test that can pick up, or for that matter, any cancer cell. Like we can pick up infections or active infectious cells with the bloods. So circulating tumor cells is a big area of research going on. There's a big research going on in that, and but I'm unaware of any test that can pick up melanoma in a blood. So, and yeah, to my knowledge, I haven't heard of increased incidence with transfusions. Yeah.
So if we could just again thank Dr. Joshi for his time and effort. Okay, so one of the important things to remember with melanoma, as I think Herman clearly articulated, is that it's a very dynamic and exciting time in relation to the treatment and options available to patients. And with that, while they're in progress, it means that sometimes there's clinical trials and there's restrictions in access, and also some of the treatments that were mentioned need to be privately funded because they're currently not listed through the pharmaceutical benefits scheme. And so that's where Melanoma Patients Australia has worked quite heavily on your behalf in trying to lobby the government and lobby pharmaceutical companies to make those drugs more accessible. And I think the first step moving forward was the listing of Ipilimumab, I can never pronounce it correctly, or commonly known as Yervoy. And I think that that is a step forward because that has brought a treatment that has proven results, as Dr. Joshi showed, to be very accessible and affordable to all patients. It's still concerning to us as an organisation that patients may need to fundraise or take out mortgages or look to borrow funds in order to access treatments. And some of those treatments are available elsewhere. So we are still working on that, and be aware that if you're in that position, to let us know and we will definitely get behind you. But it is a really exciting time because with these treatments come choices and greater treatment pathways with better outcomes. And so I did have the pleasure earlier this year of attending a discussion over in Canada with other melanoma organisations, and the buzz at that conference was about melanoma as a chronic disease and with survivorship. And we're seeing that it not progressing. And I think what Dr. Joshi was showing us is that that is coming into play and is definitely on the horizon. And our members around Australia are showing some pretty amazing results.